Naturally, I went for the red button. So today I've been asked to talk about clinical studies. Do we have an answer? I have no financial relationships with any commercial entities that I need to disclose for this talk. So do we have answers? We have a few answers. We definitely have had some consequences about our concerns about pediatric anesthesia-induced neurotoxicity. 2016 in the United States, the Food and Drug Administration issued a warning in which they said repeated or lengthy use of general anesthesia, sedation drugs during surgeries and procedures in children younger than 3 years of age may affect the development of children's brains. I know for my department and many other departments in the United States, we've changed our consent forms to reflect this warning. And they've also changed the labeling for many of the anesthetic drugs used in the United States or in the world. So what are some of the unanswered questions? We still don't know how anesthesia toxicity would manifest itself in childhood. We presume it's during infancy, but the clinical studies don't necessarily show that. We don't know the safety of longer duration of general anesthesia in childhood. We don't know the effects of repetitive anesthetics. We don't know the time of maximal vulnerability to general anesthetic neurotoxicity. We don't know if there's a specific group of children that are at heightened risk for anesthesia neurotoxicity. And also we don't know if there's synergism from anesthetic factors in toxicity. So if you have an anesthetic where the child becomes hypotensive and then perhaps has toxicity from the anesthesia, is that worse? We just don't know those questions. Well, we haven't answered those questions. So there are a number of, I've just pulled 13, but there's lots and lots of retrospective studies that show an increased risk with anesthesia receipt at a young age, say under 4 or 5 years of age, and later problems with school or doing well on neurocognitive tests. Most of these are large database studies, just showing the association, but not all of them. There are studies out there, including large database studies, that show no increased risk. But in this group, there's actually 3 sibling match studies that show no increased risk. There's 1 prospective study that shows no increased risk. And I would submit that matching with siblings, whether they're twins or just siblings, is probably a better way, if you can do it, to match than hard matching across a variety of characteristics. I'm just going to bring a few of studies forward. This one is from Bob Wilder. It's 10 years ago. The reason I bring it forward is I think it's the first clinical study that was out there. And they looked at over 5,000 children, of whom 593 had been exposed to halothane anesthesia before the time of pulse oximetry, and then followed their school experience, and found that those who had 2 or more anesthetics had roughly double the incidence of school referrals for learning disabilities. Caleb Ng, who I think is in the audience today, looked at the Western Australian pregnancy cohort, a cohort of children that was designed to look at the possible negative effects of fetal ultrasonography. And he looked at these children. He had 2,608 children that were assessed, of whom about 12% were exposed to anesthesia before the age of 3. And he determined that there was an increased adjusted risk ratio for disability in language and cognition with even a single exposure to anesthesia at a young age. Miki Bartels, again 10 years ago, did the first and only monozygotic twin pair study. And she looked at exposure before the age of 3 and then between the ages of 3 and 12 years of age. And she found that exposure before the age of 3 was associated with significantly lower education achievement scores and more cognitive problems. But the hooker was that the discoordinate twin, the twin that did not get the anesthesia, had identical scores. And you can see here, it doesn't matter if you're male, you're female, whether you were exposed less than 3 or ever exposed, your scores are identical. And then some of the more recent studies, James O'Leary from Ontario here in Canada looked at a population-based study looking at children who underwent the early development instrument, which is all Canadian children do before they enter first grade. So he looked at in his cohort, he had 188,000 children. And he determined that 28,000 were exposed to general anesthesia before the age of 4. He looked at each of the 5 domains that's part of this developmental test and determined that only an additional 0.6% of the exposed group had developmental vulnerabilities as defined as less than the 10th percentile on one of these subgroup tests. Interestingly, he found that children ages 2 to 4 were at risk, not the infants, which is exactly not what you would expect from the animal data. He also found that the frequency of exposure had no effect. Ruth Graham from Manitoba looked at the same test, the same school readiness test. She had 18,000 children in her study. About 3,850 were exposed to anesthesia before the age of 4. She also found that the vulnerable children were those ages 2 to 4, not the infants. And the particular domains that they were at risk for were communication and general knowledge and language and cognition. She also found that frequency of exposure had no effect. So she reported the type of cases, the case mix of the kids that were 2 to 4 that were at higher risk. 57% of those procedures were dental rehabilitation. So she also reported that she hard matched on birth year, sex, mother's age at birth of first child, income quintile, urban versus rural status. So that seems like it's pretty intense matching. I was curious as to what are the demographics of children that need to undergo dental rehabilitation between the ages of 2 and 4. And I could not find a study of first-time dental rehab patients. But I did find a study in 2003 that looked at 234 children who needed repeat dental rehabilitation. And of that group, 90% had chronic illness, renal disease, prior neurologic disease. 10% were ASA 1 and 2 categories. And the characteristics of that group, according to the study, were characterized by continued use of the bottle, poor cooperation, difficult personality, parents not brushing their teeth, dysfunctional social situation, failure to return for postoperative appointments. And I would say those social situations may, in and of themselves, put these children at higher risk for not doing well in school. So I think this points out the difficulties of hard matching and propensity scoring in some of these retrospective studies. Let's see, which one is this? Oh, and then James O'Leary went back to his original cohort. So he looked at the children from Ontario, where he had originally 188,000 children. He developed 10,897 sibling pairs. And he looked at the early developmental instrument test, which on his group was done at a mean age of 5.7 years. He found no significant differences in early developmental vulnerability and no significant differences in the 5 major EDI domains. So I'm here with Lena Sun, and she's probably going to correct me, but she was the primary author and investigator of the PANDA study, and that was a study that looked at the association between single general anesthesia exposure before the age of 3 and later neurocognitive outcomes. She developed a study of 105 sibling pairs who were all within 3 years age difference between them. 90% of the exposed group were males, 56% of the non-exposed were males. The mean time of exposure was 17 months, and the mean time of their primary outcome, which was IQ, was 10 years of age. And I think this study, more than any study I've ever looked at, points to the really, really difficult aspects of doing clinical research in children. She screened over 9,000 patients and basically ended up with 1.1% of the screened patients that ultimately enrolled. It's a lot of work to do clinical work in children. The good news for our specialty is that she found there were no differences in siblings between exposed and non-exposed siblings when she looked at IQ and when she looked at her basic other types of analysis. The MASK trial is, I think, still going on in Minnesota, but there have been 2 studies published as a result of that. This is the MAYO anesthesia safety in children's or in kids trial. They're looking at children born between 1994 and 2007. They did propensity-guided matching for non-exposed, singly exposed, and multiply exposed children, and they used the prospective operant test battery, and which was done at children ages 8 to 12 or 15 to 20 years of age. And they did cluster analysis in their first paper where they basically divided the results into quartiles for both exposed and non-exposed patients. And they found that there was little evidence, and the children had to be exposed before the age of 3. They found little evidence that children exposed to procedures requiring anesthesia showed deficits in the operant test battery. You might want to know what the operant test battery is. And so basically it is a type of a measurement or machine that measures the abilities of primates and now children to do various tasks. So they educate the children to the tasks, and then if they do the task correctly, children get nickels and animals get food pellets. And the animals are rhesus monkeys. And so this operant test battery for the Mayo group, well, they looked at learning, motivation, impulse control, and short-term memory. They also looked at standard neurocognitive testing, and what they found was that there was no difference between the primary outcome of IQ between exposed and non-exposed status, but they found for secondary outcomes that processing speed, fine motor abilities were decreased in the multiply but not singly or exposed or non-exposed children, and that the parents of multiply exposed children reported increased problems in executive function, behavior, and reading. So now I'm going to do just a little bit of a deep dive into the GASP study. I was privileged to be one of the principal investigators of this trial. It was published in Lancet in February, but now you don't have to read it because I'm going to tell you what's in this study. So this involved 7 countries around the world. It was a multi-site randomized controlled trial comparing regional and general anesthesia for effects on neurodevelopmental outcome and apnea in children. We had 10 centers in the United States and 2 in Canada. And the question we were hoping to answer is, does general anesthesia and awake regional anesthesia in infancy have the same neurodevelopmental outcome? It was a randomized, assessor-blinded, multi-site equivalence trial. Because it was an equivalence trial, our primary analysis was as per protocol because we did not want to bias our results towards equivalence, but we also did an intention to treat analysis. These are some of the 32 hospital or medical centers that participated in the trial. To enter it, you had to be an infant scheduled for inguinal hernia repair, less than 60 weeks post-menstrual age. We excluded the very premature, those born less than 26 weeks gestation, or any child that had risk factors for poor neurodevelopmental outcome, with the exception of prematurity, or any child who had prior exposure to general anesthesia in infancy or in utero. We were very generous with our regional anesthesia. We allowed awake spinal, awake caudal, awake spinal plus caudal, any of these plus a chloroprocaine continuous caudal infusion. I think the chloroprocaine was only used in the United States. We have a reputation for slow surgeons, and I think we probably really do have slow surgeons. And no sedation at all. For the general anesthesia group, it was sevoflurane up to 8%, no nitrous oxide, no opioids. Airway could be any way the anesthesiologist wanted to handle it, with or without neuromuscular blockade. We allowed caudal or ilioinguinal blocks done at the beginning or the end of the procedure. I'm just bringing up the sample size because we determined that equivalence would be 5 points of IQ between the two groups. I was thinking about this. If somebody told me they were going to take away 5 points of my IQ, I'd be kind of upset. But nonetheless, if we had made it narrower, we would have had to enroll thousands and thousands of patients. So we decided we needed to enroll 722 participants to allow for 10% loss to follow-up and 10% for a major protocol violation. And our primary outcome measure was the Wechsler Preschool and Primary Scale of Intelligence done at 5 years of age. We also looked at the Bailey 3 at 2 years of age, psychometric subtests, and any clinical diagnoses of cerebral palsy or other neurologic or behavioral problems. As I said before, the primary analysis was as per protocol. We adjusted all analysis for gestational age at birth, and we reported multiple imputation and complete case data. So this is our consort diagram. We screened over 4,000 patients. Ultimately, we had 205 complete assessments in the regional anesthesia arm versus 242 in the general anesthesia arm. If you can see, we have 74 protocol violations in the regional anesthesia arm versus just 2 in the general anesthesia arm, and this was basically failed spinals, and these patients ultimately went on to get a full general anesthetic. For our demographic data, the majority of our patients were male, over 80%. They were about 10 weeks of age when we did when they were enrolled, with a postmenstrual age of 45 weeks. 55% of our patients had a history of prematurity. Our outcome measure was done within 4 months of the 5th birthday. Took about 3 hours for a trained neuropsychologist. Additional tests we did were the NEPSI, the Wechsler Individual Achievement Score, the Child Memory Scale, the, I'm going to block on this name, the BRIEF scale, which looks at executive function, the Adaptive Behavior Assessment Score, the Child Behavior Checklist. And there are 4 scores as part of the WIPSI, and this is normalized or was normalized for each country to give a mean of 100 and a standard deviation of 15. Parents were also asked about visual or hearing difficulties, any neurodevelopmental interventions, whether their child had ever been diagnosed with cerebral palsy, autism spectrum disorder, or ADHD. And here are our results. And you can see that all the scores, whether you look at, this is as per protocol for the WIPSI, and if you look at the regional anesthesia arm versus the general anesthesia arm, there are virtually no differences between multiple imputation way of analyzing it or complete case in both the full scale IQ and all the sub scores. The same with intention to treat. They're virtually identical. When we look at the parental rating behavioral outcomes, you can say that they look very, very close. Whether you're looking at executive function, adaptive behavior, or maladaptive behavior, when you look at it as per protocol by multiple imputation or complete case. The same with the intention to treat analysis. And then when we look at our non-psychometric outcomes, parental behaviors of developmental issues, there's no difference between the two groups in either as per protocol or intention to treat. There is a difference between the Bailey scores of the children who did not attend the 5-year visit. And you can see over here, they're definitely lower than those that did attend a 5-year visit. But we have roughly the same amount of non-attendees between regional anesthesia and general anesthesia, and basically the scores look fairly similar. So we do not believe that this introduced much bias into our final results. When we look at the actual statistics about whether there were differences between the IQ scores between the regional anesthesia and general anesthesia group, we found none. This is the only statistical difference we found of the maybe 50 or 60 outcome measures we did. And we did not use a Bonferroni correction. We did not do, or any other statistical correction. So if you look at executive function on the as per protocol basis by both multiple imputation and complete case, there is a statistical significance with the children who got regional anesthesia demonstrating more executive function. So summary, just under 1 hour of infancy does not cause clinically significant adverse neurodevelopmental outcome compared to awake regional as measured at 5 years of age. Lots of limitations. The duration of exposure was just under one hour. The duration of general anesthetics in the United States under 18 years of age is 57 minutes, so that's why we're calling this as an intermediate length anesthetic. The exposure was during a narrow time of neurologic development, early infancy, but that is definitely where the animal data pointed us. Over 80% of our participants were male, and certain skills and functions do develop later in life, such as executive function and social emotional skills, so we may not have captured the full picture for that. But this is the strongest evidence to date that children who undergo an intermediate length anesthetic in infancy start school life with no neurodevelopmental risk factors. So for follow-up, there's many of us in the room here that are involved in the T-REX trial, and this is a neurodevelopmental outcome study looking at standard dose sevoflurane versus low dose sevoflurane, dexmedetomidine, and remifentanil anesthesia in young children. We're looking for children who are less than 2 years of age, who are expected to have surgery. We originally thought 2.5 hours. We couldn't enroll anybody, so now it's children who are having planned anesthetics longer than 2 hours. And this is a superiority trial, so the low-dose sevoflurane group is supposed to be superior than the high dose in terms of neurodevelopmental outcome. This is a phase 3 randomized active control parallel group assessor-blinded multi-center superiority trial. We're hoping to enroll 450 children, and we just started enrolling at Children's Hospital in Boston, and we've already got 5 patients. So I think the rumors that our surgeons are slow are actually correct, and it's fairly easy for us to enroll. There are 10 countries right now that are involved in this study that's sponsored in part by SmartTots. And the outcome of measure will be the global cognitive function assessed by full-scale IQ with the WIPSI test assessed at 3 years of age. So what are our answered questions? I think we have answered that the safety of short to medium-length general anesthetics compared with regional or compared to siblings and young infants is safe. And that was demonstrated by the GAS trial and the PANDA trial and one of O'Leary's trials. And large databases, at least the recent large database trials, point to small or no impact of general anesthesia on school readiness and school performance. We don't know if there's a vulnerable phenotype within these groups. The one prospective study, the GAS study, looked at ASA 1 and 2 patients. We don't know if a diathesis stress model would hold, meaning if there's an interaction between predispositional vulnerability and a stress caused by anesthetic toxins or rocky anesthetics. And then we don't know the effects of really long or repetitive anesthetics or sedations. And it reminds me, my very first night on call at Boston Children's Hospital was a Saturday, and I did a 23-hour case. I've never done that since, but we do some really, really long anesthetics in pediatric anesthesia. Directions for the future, I think we need to study longer duration anesthetics. T-REX is going to try to get to that, but we're not going to have that many really long anesthetics. We need to look at repetitive anesthetic exposures, determining whether there's certain children that are at higher risk. And I think most importantly, we need to work together at SmartTots to study and improve the conduct of anesthesia in general in young children vis-a-vis brain health. And to me, that would be involved improving the guidelines for monitoring and goals for blood pressure, end-tidal CO2, glucose, temperature, oxygen levels, and positioning, and determine the role of NIRS in pediatric anesthesia. With that, I'm done. Thank you.